Okay, thanks very much, Maggie. So next we're going to hear from Lauren Beaupre, who's from the University of Alberta, Canada, and talk about her experiences of trial in a similar population.
So thanks very much. I'm really excited to be here and to be able to actually present with Maggie, because Maria and I were talking about these trials when they were being developed, and so a lot of our things really align, although we found slightly different findings with our group. What do I have to do to make it go here? Go here. What do I do? Oh, there we go. Okay. So, so we had done some previous work that really trying to get to this group that was living in a nursing home, because these so often are people who are excluded from rehabilitation and excluded from research. So we don't, even when people are doing trials, they're not looking at this group. So we've done a few cohort studies, and actually our longitudinal evaluation, which was a REGAIN 1, was meant to be a control group for this, this trial. It didn't end up working that way, but I'll explain that in a few minutes. So then we worked on in some of our other work in looking at, could you actually do rehab in people who had dementia? What was the evidence for it? And this systematic review was initially looked at, so can you do rehab in people with dementia following hip fracture who were residing in nursing homes prior to their hip fracture, and there was virtually no evidence on the nursing home subjects. So we sort of cut off that phrase and said, okay, what about rehab for people with dementia? And this basically said that yes, people can respond positively even with dementia after hip fracture and should be included in rehab programs. But we really wanted to get into the nursing home setting, so we actually went and surveyed then within our province, what were people doing in nursing homes? So talked to rehab staff to say, were you providing rehab? And basically the answer was yes, but we're highly constrained by our staff resources. We simply can't feel like we're offering enough. And that yes, cognitive impairment was highly prevalent, but this was a manageable barrier for the people who were working in these nursing home settings. So that allowed us to move to our first sort of interventional study, which was, can rehab actually improve the outcomes for people who were living in nursing homes prior to their hip fracture? So we did a rehabilitation outreach team. This was very much focused just on physio and sort of the rehab versus Maggie's more diverse program that looked at geriatrics and nutrition as well. And we actually ended up creating treatment teams, and when we started to advise, we did a few little pilot runs to say, what should it look like? How should we deliver this care? And initially our thought was that we would have a physiotherapist and physiotherapy assistant, or PTA, deliver the program, because many patients, they go back early and they actually require two-person assistance to ambulate, to mobilize, to get out of bed. What we actually found from the physio after working for a couple of sessions or with a couple of these patients, said, this is overkill. Physio actually doesn't need to be here for every session. The program we're delivering is quite straightforward. So what we actually ended up developing as our program was that the physio and one of the PTAs would go in first thing in the week. They would assess the patient, set up the program, provide the treatment that day, and then for the other 2 sessions of the week, 2 PTAs would go in independently of the PT and deliver the program. And this is certainly allowed within our legislation within Alberta. And this is with PT oversight. So the physio was available by phone or by pager, but the PTAs could actually deliver this program, which was a pretty straightforward program. And this really helped to reduce our costs. So we had one of the reasons that we sort of did this as a non-randomized trial was I wasn't quite sure what the intervention was going to look like. And as a colleague of mine likes to say, physical therapy is a profession, not an intervention. So it's inadequate to say we did physiotherapy. That tells people nothing in terms of what we actually did. So we really wanted to, because there was lack of evidence, be able to describe the program that we were doing. And much like Maggie described, we were really looking for a program we thought we could engage these patients in, because you weren't going to be able to do a lot of communication. Many of these patients were pretty much nonverbal in terms of being able to have conversations with our rehab team. So we had bed mobility, things that we thought we could engage patients in that they did every day and that they would want to be able to return to be able to do it more easily. Transfers, we tended to be opportunistic. If they were in bed, we got them out of bed. We worked with toileting, transfers, lots of sit to stands, which we used as kind of resistance training for them throughout that treatment. Real focus on ambulation. That was our key parameter for deciding who would be eligible for participation. They had to be walking prior to their hip fracture. And so we thought this is an activity that this group should want to return to. And finally, we did move to functional exercises, again, as much as we could engage people in them. And we didn't say this is, you have to do treatments like this at every session. Rather, we said, these are the components of treatment session, and you must tell us what you did. So we were really, made the physios and the PTAs really document how much time they spent on each of these activities and what they specifically did. And that analysis is still underway to really look at the content analysis of which of these parameters worked the best. So we did this as a, I wasn't brave enough to randomize. I was really worried about having a negative trial because we didn't know enough about the intervention. So I thought, I don't want to have a negative trial, publish it, and never be able to get funding again to do work with this group when we don't know what we're doing. But I did want to do a comparative design. So what we set this up with as a pre-post with concurrent control group. And what that means is we used a before-after study. So Regain 1 was our before. Then we had a group that we said, here's the intervention group. But at the same time as we were allocating some patients to the intervention group, we were also allocating some patients to continue on with usual care. And what that allowed us to look at was to say, okay, if we just compare the before and after, how much of the change or the difference between these groups can we actually attribute to what we did, and how much might be as a result of other things that are happening in the system that might also affect changes in there. And this was actually a really good thing that we did, because two things happened, one good, one bad, and in the end, we actually didn't use the Regain 1 as a control group. So the bad thing was that there was legislative changes within our province, and so patients who were considered nursing home residents in Regain 1 actually became residents of supportive living in Regain 2. So what this meant is this was the group with significant dementia who were ambulatory with lower levels of comorbidity, higher levels of functional independence, and they were now in facilities that were staffed by healthcare aides, licensed practical nurses with RN oversight. No rehab in sight in those facilities. The nursing home residents then, and this is hard to believe because I thought Regain 1 cohort was really fragile. Patients in Regain 2 were older, they had more comorbidities, they were more functionally dependent, so they were actually worse, significantly lower quality of life and worse than the Regain 1 cohort. I actually didn't think that was possible, but that's what you have. The good thing that happened was at the same time we were implementing this regional care pathway in the acute care settings that was really focused on early surgery and early mobilization. In Regain 1, almost half the patients died within 12 months of hip fracture. In Regain 2, the older, sicker, functionally dependent people pre-fracture had a 30% mortality rate. And so this is, I think, talks again about the importance of seeing these patients, these nursing home residents, regardless of their fragility and where they are on this scale. You need to get them up, you need to get them moving post-op and treat them the same way you would see people that are living in the community. So anyway, we ended up focusing instead on just the Regain 2 cohort. Our primary criteria for entering the study was that they were ambulatory pre-fracture. There were no cognitive criteria. It just didn't matter what their cognition level was for inclusion. We assessed them pre-fracture, just asking what were they like, how were they moving before they had the hip fracture, then immediately post-intervention, which was about 3 months post-fracture, and then again at 6 and 12 months post-fracture. Our primary outcome was a functional independence measure, or the FIM, which is actually not my favorite measure for this group because it includes a multi-dimensional assessment of things like eating and bathing and grooming and self-care. And these were actually not things that we thought we would affect in people who had such significant dementia. And so we really focused on the FIM motor score overall, but also on the transfer and locomotion subscales of the FIM, because that was really where we were directing our care. We wanted to make these patients easier to mobilize themselves and easier and make it so they're returning to ambulation. We also used the EQ5D for quality of life, and we did secondary evaluations. And one of the key ones that we did was the treatment fidelity of what did the treatment actually look like, what kind of physiotherapy we were delivering, and what were these patients tolerating and able to participate in. We also did cost effectiveness, and we also did the qualitative evaluation both with the nursing home staff and the outreach team. So what did we find? Oops, going so fast. So they were old. Our average age was also 88, but we had a 104-year-old participate in this trial as well. They were also primarily indoor walkers, and what I mean by indoor walkers is that they were walking within the facility, but if their family took them out of the facility, they typically went by wheelchair. And so again, you can see impaired quality of life, impaired BIM scores, but fast time to surgery and fast time to mobilization. And cognitive impairment, again, 75% scored as severe as less than 13 on the mini mental status exam. So again, highly impaired cognition. So of 46 participants, and this was where we were not as well integrated as the Australian study, we had to get signed consent from the proxy respondents. None of our participants provided their own independent consent. And there was significant delays in this. Patients didn't stay very long in the acute care setting. And so we ended up having to do a lot of these conversations by phone and then having to mail out consent forms and then return them because we legally couldn't go into the facilities, nursing home facilities, until we had that signed consent. So this ended up really delaying them. And we actually lost a substantial proportion of our intervention group because of these delays. They deteriorated or died very shortly after returning to the nursing home, which again speaks to this narrow precipice that they're living on. If we want them to survive, we need to treat them quickly. So, but of the 35 active participants, most of them actually continued on with the program and did very well with it. We had only 5 patients who were discontinued. 1 died. One was very combative and was swinging her walker at the outreach team, and they felt that they were probably more likely to make her fall being there, and she was going to ambulate anyway, and the other 3 were just deteriorating to the point that they were not responsive to rehabilitation. But if we actually look at the program, and I think this is the important part and the important difference between what they did in Australia and what we did here in Canada, is we had a much more extended program. We went for 10 weeks. And so again, you can see that they have good participation in the in the sessions that they were able to do. They were long sessions, right? It took a long time to engage these patients and get them to do things. And some of that might be because a lot of this care is delivered by PTAs who tend to be nicer than PTs and probably give the patients more rest. But you can really see the focus in the treatment as you went out past the 5-week mark, that we changed from a transition from less focus on bed mobility and much more on ambulation and the functional exercises. So this is a long process to recovery, and you need to give them time to do recovery. If we go specifically into ambulation, what's really interesting with them is the improvement between week 1 and week 5 is substantial, but look at the improvement that happened between week 5 and week 10. You know, they more than doubled their median walking distance again. The amount of personnel that was required to mobilize them and the amount of assistance required for those personnel substantially reduced. So again, this is really important in talking about what does the treatment need to look like. So these are the comparisons for us between the usual care and the intervention group, the group that received the outreach program. And so the mobility score on the top left is talking about the transfer subscale of the BIM. Locomotion is the ambulation subscale. Physical is the actual physical domain, and then the EQ5D. So unlike the Australian study, we saw a modest bump. And again, remember, 88 years old, pretty functionally dependent. So modest bump, but what was impressive to us is I actually expected the exact same results as what we've seen in Australia. I thought we would lose them, and they would come back down. If we stopped the rehab, that they would then lose it. But what this told us is that if we could get them to that point, right around that 3-month mark, clearly the team, the sort of nursing home staff that we hadn't really engaged, continued to keep them moving at that point. We may have gotten to a point that the nursing home staff would actually take that over. I think even more importantly, and this speaks to perhaps some future trials we might focus on, that top line of the people who are doing particularly well, that is the group who are ambulatory both in and out of the nursing home. So if you have really good ambulators in nursing homes, they are very responsive to rehabilitation, and so they maintain it. And so when we look at the people who received usual care, who are outdoor walkers, they only did as well as the indoor walkers who received the intervention. So there's a real loss there of what their potential rehab was. And I think that speaks to where we might go going forward. When we did sort of adjusted analysis, so we could control for age and sex and pre-fracture function, the 2 factors that really emerged to be about who would recover most strongly was related to being in the intervention group and also those who were outdoor walkers pre-fracture. Our cost effectiveness analysis, this was about 2,300 Canadian to provide that intervention, but we actually still ended up cost savings over 12 months. And the reason for that was because the usual care group had far more hospital readmissions that were really expensive. So getting these patients up, walking, and mobile reduced their readmission rate and actually made that very expensive rehab program cost savings, so that the intervention group cost the healthcare system approximately $1,300 less than the usual care group. Our qualitative analysis, we did it with the outreach team, and one of the things they noted, and this was certainly something that we picked up, was that we were separate. We came in and we worked with without the staff, and so the staff were very receptive to us being there. But it was like, great, you're here. And in fact, they would say it was a treat. It was extra that they would come in and do this. But it did remind them that they were supposed to be doing things as well with patients. That we should be thinking about these patients as being able to mobilize. So, what does this mean? We came away saying, look, this is feasible. If you can get this group to respond to rehabilitation, we should not be fearful of including people with significant cognitive impairments in rehabilitation programs. The program, the effect was modest, but it was measurable and it was sustained. And there may be, if we really focus on those who are highly ambulatory pre-fracture, they certainly are able to respond to rehab. So future work, I think we still need more work to figure out the duration, the intensity, the frequency. We know we need to prolong it, but I don't think we've completely honed the intervention down. And we need to engage with the nursing home staff to sort of hopefully continue and carry on and maybe get them engaged more early in the care. So the take-home message, cognitive impairment is not a contraindication for mobilization and for rehabilitation. You need to, as Maggie said, get them up and get them going. So thanks very much. I'm really pleased to have the opportunity to present this.
Okay, thanks very much, Lauren. I think we've got a short video to play and then we'll have time for a few questions.